Toronto Joint Center for Bioethics Seminar Series. I'm Andrea Bianchi, and I'll be the moderator for today's session. Our speaker is Jennifer Bell, and her seminar is entitled Influences on Patient Autonomy and Decision-Making about Early Phase Cancer Clinical Trial Participation. Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. We would like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now it is my pleasure to introduce today's speaker. Jennifer Bell is a bioethicist and clinician scientist at the Princess Margaret Cancer Centre, University Health Network. She is an assistant professor in the Department of Psychiatry and Dalla Lana School of Public Health and member of the Joint Center for Bioethics at the University of Toronto. In 2020, Jennifer received the CIHR Cancer Research Institute Early Career Investigator Award from the Canadian Association of Psychosocial Oncology. So Jennifer, we'll hand it over to you, and I'm going to share my screen with your slides.
Great. Thank you, Andrea. I'm going to pause my video so that I can focus on the slides. So as that's being set up, the title today for my talk is Patient Autonomy and Decision-Making about Early Phase Cancer Clinical Trial Participation. Perhaps there's a bit of delay. I'm not seeing the slide advance.
Okay, are you able to see them, Jen?
I can see the first slide.
Okay.
But I'm ready to move on to the next.
Perfect.
Got it. I just wanted to disclose a couple of things. The first is that we are actually very grateful to have received Canadian Institutes of Health Research funding for this research. And I myself have no financial conflicts of interest to declare for this presentation today. I also want to acknowledge my very diverse and supportive and engaged multidisciplinary research team. And in particular, I want to highlight the postdoctoral researcher on this project, Dr. Jonathan Avery, who really took the lead on data analysis. But really, this was a team effort, and we're currently writing it up for publication. But I really appreciate the efforts of all of the team members that have contributed towards this project. So by way of an outline, what I'm hoping to accomplish with you today is to review a bit of background on the issue, review with you some theory and as well a previously developed model called ACT. I'll then go over quickly the study design of the current project and the methods, and then review some of the emerging findings, as well as next steps and conclusions. So there continues to be difficulty recruiting sufficient numbers to cancer clinical trials across the globe, and this has been exacerbated by the pandemic. It's a problem because clinical trials are crucial for developing novel therapies that are effective against cancer and that provide the evidence to help practitioners and patients make informed treatment decisions. When considering how to maximize accrual of trials, though, a key ethical concern is advancing research while ensuring patients' relational autonomy and informed consent. Now, relational autonomy involves the capacity for meaningful choice, which can be constrained or promoted by internal and external factors and resources, such as socioeconomic status and social support. Relational autonomy is the guiding theoretical framework for this program of research. This theory has its origins in feminist philosophy, and applied, it can be characterized as a type of feminist methodology, which acknowledges the patient as a socio-political identity, where illness is inherently destabilizing to a sense of self and one's capacity. The theory recognizes power imbalances within interpersonal, social, and structural relationships, and that the patient identity may be further layered with gender, race, class, and sexual identity complexities that shape the autonomy skills and particular experience of being a patient within healthcare. Relational autonomy is applied as a theoretical lens throughout the research, and I do have a paper that was just published in the International Journal of Feminist Approaches to Bioethics that elaborates on relational autonomy as a method if you're interested. So the current research really builds upon our previously developed theoretical model of patient decision-making about cancer clinical trials, where we use grounded theory and relational autonomy. This model, which we call ACT for short, is based on the experiences of patients making decisions about later phase cancer clinical trial participation. So briefly, there are three overarching stages of the decision-making process that emerged from this research. Firstly, there's predisposing factors, such as beliefs about trials, which are rooted in culture or historical experience, which leads patients to be either open or closed to receiving a trial offer. There's the trial offer, how physicians bring up the trial, for example, and how they discuss the trial with patients and their support persons. And there's the decision-making process. So the process and the type of decision-making, which we identified as either snap or reflective, exhibited by the patient. So if a patient is a snap decision maker, they usually make a quick choice based upon the trust and recommendation of their provider. If a patient is a reflective decision maker, they engage in the sub-processes of seeking information and weighing pros and cons to arrive at an all things considered decision. The final step is the decision, and for some, a revisiting of the decision. And the purpose of the model is to really provide a robust understanding to inform the development of tools, resources, and policies to enhance patients' relational autonomy within clinical trials. So applying relational autonomy to this research helped to uncover some key sociopolitical influences embedded in the model, which are briefly inequitable trial access due to, for example, structural or physician gatekeeping. So that would include potential biases influencing screening patients for trial eligibility based on social factors. Other structural factors impacting inequitable access are the inability of centers to host trials due to a lack of resources. And this limitation immediately forecloses accrual of patients at that center. Also, there's complex research protocols with multiple arms and correlative studies that make some trials harder for patients to understand and participate in if they require a lot of time and effort to participate. It identified the therapeutic misconception where patient perceptions were of the trial as treatment and that it will improve their health, which may be influenced by research statements that cast trials as part of the care continuum, thus blurring lines between treatment and research. Identified was problematic power differentials, such as within the patient-physician relationship and family dynamics. So for example, where the patient interprets the physician as bringing up a trial as a recommendation for them to participate, and patients having concerns about not negatively affecting their relationship and care received. Family dynamics include family pressuring patients to make a particular decision, not because the patient wants it, but because the family thinks they should. And we discussed these issues of unjust gatekeeping and inequitable access to trials in a recent paper in Cancer Medicine. So to ensure the ACT model is comprehensive, we wanted to see if it fit and worked in the early phase cancer clinical trial context. So phase 1 trials, often the first phase of testing toxicity in humans, are more ethically contentious than phase 2 or phase 3 trials because research participants are more likely to experience adverse effects or unexpected toxicity while receiving minimal or no benefit. Phase 1 trials frequently involve patients whose disease is advanced or refractory to standard treatment and may be more likely to perceive early phase studies as their last opportunity to receive treatment. And patients' desperation in this context may undermine their capacity to provide information. The therapeutic misconception has been particularly problematic for patients considering phase 1 trials. Historically, these patients are more likely to interpret clinical benefit in the face of contradictory evidence. Over 10 years ago now, the authors of a literature review on patient comprehension of phase 1 trials during the consent process concluded that less than 45% of patients understood that dose determination was the purpose of the trial. So recent advancements in cancer biology and precision medicine, followed by the success of several transformative therapies, like immune checkpoint inhibitors and molecularly targeted agents, have altered the cancer clinical trial landscape. These sort of breakthrough therapy trials have the potential to be highly targeted and are now incorporating elements of later phase clinical trials, so dose expansion, escalation, and adaptive design, depending on a drug's early evidence of efficacy and acceptable toxicity. These trials blur the policy and regulatory distinctions between trial phases and challenge previous understandings of risk-benefit of phase 1 trials. There is renewed hope and belief in this landscape of patients and clinicians alike that these drugs will work. Thus, special attention to the quality of preclinical evidence and informed consent procedures is required to ensure participants' understanding of evolving safety and efficacy data and realistic optimism. So the purpose of this research is to qualitatively explore patients' early phase clinical trial decision-making through a relational autonomy lens. And learnings will help us confirm or refine the ACT model. And a robust understanding is practically important for clinical trial programs, medical oncology, supportive care, in order to guide the development of tools and resources to enhance patients' autonomy within clinical trial procedures. So as an overview, this was a qualitative study design using interpretive description, and we aim to sample patients, support persons, and clinical trial personnel. We conducted open-ended interviews and analyzed the data using a constant comparative approach with a relational autonomy lens. Our research took place at an urban comprehensive cancer center with a renowned phase 1 trial program. All the patients interviewed except one had accepted a phase 1 or phase 1/2 cancer clinical trial of immunotherapy. Some had previous experience withdrawing from a trial or declining a trial in the past. Slightly more male patients participated, and patient participants were also more likely to have college, university, or above level of education and made between $30,000 and $60,000 a year. The patient sample varied by cancer type. Most identified as Caucasian, and 2 participants' primary language was non-English. Support persons were mostly female, and clinical trial personnel were mostly female. And trial personnel had a variety of years of experience in their respective discipline and in clinical trials, with several over 30 years of clinical trial practice. In the rest of this presentation, I'll primarily be drawing upon the patient participant data. So, of the emerging findings, all patient participants considered participating in an early phase cancer trial. However, the extent to which they perceive themselves as having a choice to participate or not emerged as a central construct of their experience. Perceptions of choice were subjective and varied according to whether participants characterized their experience as either an act of desperation when standard care was seen as unsuccessful or no longer an option, or an opportunity to receive novel treatments to potentially extend quality of life, pursue longevity, and/or be cured. These divergent experiences exemplify opposite ends of a choice spectrum, where desperation coincided with the experience of having less choice, and opportunity afforded participants a sense of greater choice. Interpersonal and structural factors influenced patient participants' place on the choice spectrum. These factors included being provided with some hope, having trust, and having the ability to opt out. So, trial participation as an act of desperation. Despite research consent forms that identify alternative options to trial participation, some participants believe they did not have a choice but to participate in an early phase cancer trial. These participants experienced standard forms of care such as chemotherapy, radiation, or surgery as ineffective at treating their cancer or intolerable. So treatment side effects were too difficult to manage, thereby impacting their quality of life. A minority reported never being presented with standard options by their oncology team because of the severity of their cancer. When faced with a life-limiting diagnosis and no viable standard of care, participants felt they had no other option but to enroll in an early phase trial. As mentioned by this participant, my understanding is they, ET staff, trial staff, don't really know if it's going to help me. They definitely told me it wasn't a cure, but the chemo really wasn't working. And when you're told this is terminal, what are you going to do? There's no other road as far as I myself am concerned. We're out of options. The belief that death was around the corner caused a great amount of anxiety in some patient participants, contributing to their sense of desperation for participation, even when faced with potential side effects from the trial. If the person wanted a chance to survive and or extend their quality of life, they felt they had no other choice but to consent. So P10 emphasized, it's very scary. I was petrified of what the side effects could be from the trial. But again, you don't have a choice. If you want to stay here, stay alive, you're going to do it. Some participants internalized a sense of pressure to make a quick decision, lest the trial opening would be filled by someone else, contributing to their feelings of desperation and perceived lack of time to make a considered choice. So P11 said, there was pressure to make the decision in a hurry. They, trial staff, have to fill these spots. They only have a certain amount of time for you to make the decision. Eventually, you're going to get to the point where we have no choice. You have to go for a clinical trial. Interestingly, time pressures were experienced differently for some patients. For example, P2 was informed by their treatment team that early phase clinical trials were not yet an option because the patient had not exhausted more proven lines of cancer therapy. Waiting for a trial to become available became a point of contention for this patient participant, who was desperate to receive the immunotherapy trial drug as soon as possible because they perceived it as the best treatment available. So P2 said, after it, immunotherapy trials was mentioned. I kept pushing for it. I wanted to try it out. I was willing, but the doctors kept saying, that's something to keep in your back pocket. That's for later. I'm going, well, later on, maybe too late. So for this patient participant, waiting for a trial was distressing, since at the point at which they would be eligible, they worried they would be closer to death and not in a position to benefit personally from the experimental drug. This situation highlights the lack of power or control patients have over the trial process. Patients have to be in their sweet spot to access the trial. They can't be too late, too early, sick, or too well. Moreover, the timing is not up to the patient, but up to the system. When trials open and how long they're available, by what criteria patients are determined to be eligible, when trials are presented to patients. This is all typically out of the patient's control. In advanced cancer context, lack of control can be very distressing and potentially undermining their autonomy.
Jen, my apologies, just letting you know that you're fading in and out a little bit right now. So just, I'll let you know if it becomes a problem to understand you.
Oh, okay. I will try and move closer. Maybe that will help.
That's already better. Thanks, Jen.
Okay, I'm trying not to lose my voice. Okay, the next slide, Andrea, I think. Okay, so trial participation as an opportunity. In contrast, those who believed they did have a choice, had come to terms with their expected mortality, which in part allowed them to more critically evaluate their treatment options and quality of life. For these participants, early phase trials were characterized as an opportunity to try a novel treatment that could provide a better quality of life when compared to standard forms of care. So P5 said, chemo, when I looked at the chemo side effects and also the clinical trial side effects, they're also similar. I figured, you know what? Why not just give it the trial a chance? Because we'll never know until I give it a try. I just feel like this is something that could work. So participants who felt they had a choice and perceived participation as an opportunity were able to compare the risks, side effects, and success rate of standard forms of care with the risks and promise of the early phase trial. The logistics associated with participating, so traveling to the cancer center, for example, for treatments and follow-up care, were also considered when making a decision. Most participants who felt they had a choice appeared to balance the pros and cons associated with participating against the trial's impact on their daily routines lifestyle, and on their desired quality of life. This type of decisional balancing and consideration as to whether the trial aligns with their values is reflected in the following quotation from P16. This person says, "I felt I had a choice. I was offered the trial, but I didn't accept right away. I was reluctant. There was a greater commitment to participate, and perhaps a greater risk of side effects. My big concern was quality of life. As long as I can still think and write, I'm good. This seemed like an opportunity." So these divergent experiences between trial participation as an act of desperation or as an opportunity exemplifies opposite ends of a choice spectrum. On the one end, a sense of having a choice and exercising authentic agency through decisional balancing, as demonstrated by many of these patients weighing pros and cons and evaluating the potential impact of the trial on their quality of life. On the other end of the spectrum, some patient participants perceived a lack of choice, motivated primarily by fear of impending mortality. A myriad of psychosocial and structural factors influenced patient participants' place on the choice spectrum and whether they experienced a greater or lesser degree of choice. So CT provides some hope. Patient willingness to participate in an early phase trial appeared to be influenced by their sense of hope that the trial would be effective. Perceptions of hope were supported by oncologist or clinical trial personnel body language, tone of voice, and choice of words when trials were introduced and discussed. Conversations between clinicians and patients that were transparent about the experimental nature of the trial were nonetheless perceived by some patient participants as providing them optimism and a sense of hope that the trial could benefit them. For example, some described receiving information about the uncertainty of personal benefit from the trial, yet remained hopeful that the trial could potentially extend their quality of life. As stated by P7, the doctors themselves, they don't know if it's going to help. They definitely told me the trial wasn't a cure, but it could give me more time, hopefully. For participants who believed they were going to die and were desperate to receive positive information, a renewed sense of hope was nurtured when clinical trials were discussed or introduced, especially when the introduction of an early phase trial immediately followed the receipt of bad news, such as recurrent disease or tumor growth. P16 said, "It was made plain to me that I am not in good shape. And then you see the trial came along with a certain amount of optimism, as if to say, well, you're really far gone, but guess what? Here's a chance." Patient participants also appeared to derive a sense of hope from all the medical tests that were required to determine if they were a candidate for the trial. Participants noted that these medical tests made it seem that the trial was highly personalized, and that passing tests and going through all the prep work would mean that the trial product might work better for effectively combating their disease. P15 said, "I did a bunch of tests, so they knew how good or bad of a candidate I was. And they said, you're like a perfect candidate. So it was a no-brainer to participate." This idea of being the perfect candidate and the impact this had on the no-brainer decision to participate illustrates how the structural context of trial workup, reinforced by clinical trial personnel's reported description of workup results, can contribute to the trial decision. Thus, the circumstances under which trials were introduced and the perceived tone and interpretation of trial workup conversations were the social and structural background conditions of cancer care that appeared to encourage hope and influence some participants' decision to participate. The construct of hope was also influenced by the new trial landscape in precision oncology. A clinical trial personnel participant said, "I think what has really changed is that patients are given more hope. It's different with precision medicine because we're tailoring and targeting different biomarkers or factors or characteristics of the disease. It's still about learning about the medication and learning about the combination, but it's more meaningful for the individual, which translates into having more hope." The next quote is from a patient participant who talks about immunotherapy trials in particular. "It's using your own immune system, right? So it's more of a natural approach than chemo. It's a chemical, it's poison, right? Chemo is poison, right? And the idea is that they give you the chemical, kills, all the cells, including the good ones, and the idea is the hope that you bounce back. So here a comparison is made between immunotherapy and chemotherapy, and what a patient hopes for may be influenced by the type of therapy available. So trust played an important role in swaying patient participants to consent to an early phase cancer trial. The faith and trust patients had for the institution from which the trial was being offered was an influential factor. As P3 noted, I know that Center X is a very highly reputable hospital. They do wonders, and right now I'm relying on them. I'm putting my life in their hands and they're going to do what's best for me. That's the way I see it. Trust in the institution enabled patient participants' assessment that the trial would not harm them significantly, that their best interests are being taken into account, and thus increase their likelihood of participating. In addition to trusting the institution, patient participants were also influenced by the opinions of trusted clinical trial staff and other members of their treatment team. P9 said, "I trust Dr. X's integrity, and I trusted he believes that probably it's the best choice for me. I know there may be other trials, but since he decided, I followed. His personal contact, his professionalism promoted that trust." Another patient, P11, said, "I spoke to our oncologist. I wanted to talk to him so I could get his input. Because he's important and he's kept me going this long. He said, go ahead with it. You're foolish not to take it." The words used by this patient participant, "he's important and he's kept me going this long," emphasizes how trust in his oncologist's opinion was nurtured by his oncologist historically making treatment recommendations that benefited the patient medically. The colloquial statement that any other choice would be foolish perhaps demonstrates the established rapport between the patient and clinician. Following a trusted physician's recommendation affirms the importance of this relationship to the patient and recognizes mutually held values of helping the patient. But it does open the door to questions about whether the patient would have felt supported in making a decision to not pursue the trial. The ability to opt out of the trial if participation did not meet patient expectations also appeared to contribute to participants' decision to consent. Whether patient participants felt desperate or perceived participating as an opportunity, the ability to opt out was described as a failsafe, making it easier to, quote, take the risk for those who had concerns or uncertainty, or change one's mind if the trial did not end up advantaging the participant. P14 elaborated, "I wanted to know whether I could quit at any time. I didn't want to just be a guinea pig unless I had a chance of survival and some kind of potential improvement. They couldn't guarantee anything." Similarly, P18 felt they had no choice but to participate, but appeared comfortable with the situation because they had the option of opting out, saying the bottom line is, I didn't think I had any choice, but it's nice to know that I could have walked away at any time. Thus, the ability to opt out provided patient participants with some security and prospect for deferred choice, that if the trial was not working for them, or if the side effects of the trial were too difficult to manage, they could withdraw from the trial. The ability to opt out provided reassurance in the face of risk or uncertainty, and an option for choice despite the desperation some expressed as motivating their entering the trial. So some emerging conclusions. Applying autonomy theory to the findings may interpret patients who do not perceive a meaningful choice option as somewhat restricted in their autonomy. However, relational autonomy theory considers the issue more broadly and importantly probes the underlying conditions of choice context and how patients are supported or not in their preference formation and decision-making process, and specifically what social and structural factors may be influencing patient autonomy and how patients can be best supported in developing or exercising their capacities for full autonomy. Our interviews highlight the complexity of the decision-making process with respect to interpersonal dynamics and structural influences. Psychosocial influences that were relationally situated included a sense of desperation, ability to accept one's mortality, hopefulness, and having trust. Structural influences included the ability to opt out of the trial in the future and the way in which pre-screening or trial workups and how and when trial discussions occur with oncologists influence a sense of having options. The broader background environment within which participants considered enrolling in an early phase trial also appeared to influence choice perceptions through emotional regulation. This included the ways in which the provision of cancer care consciously or unconsciously contributed to hills and valleys of extreme emotions. For example, the timing of introducing the trial after being told bad news. There was confirmation and extension of themes from the ACT model. Similarities between early and late stage trial decision-making include the influence of trust and credibility in the institution and providers on patients' decision-making process. It is clear from this program of research that trust is a very important factor and powerful influence on patient autonomy within valued relationships and decision-making across all trial phases. Interestingly, altruism did not come up in early phase trials as a motivation for decision-making, as it sometimes did for late phase trial decision-making. Perhaps this speaks to both the context of advanced cancer, where there may be more desperation for individual benefit, and also the influence of precision oncology and the changing trial landscape, as potentially offering more targeted therapy provides greater hope for benefit. However, early phase trials have only preclinical evidence, some very sparse. These trials may demonstrate at best early signs of efficacy. This preliminary analysis needs further unpacking in terms of patient understanding of trials and the quality of evidence available. Other emerging findings that require further exploration is patients' perceptions of immunotherapy and how the belief that this is more natural because it's one's own body may be informing patients' risk assessment relative to potential benefits and hope that this drug will work. Similarly, some patients want access to novel immunotherapies earlier in their trajectory of care. They would prefer not to suffer through toxic chemotherapy if there's a promising drug on the horizon with less severe side effects and the potential to benefit. This is an important patient-driven consideration that could be better taken into account within trial design. The study has some limitations. We were working within a renowned phase 1 trial program at an urban academic cancer center with an otherwise very high clinical trial accrual rate and extremely well resourced in terms of trial support. Our sample, though, was limited in terms of diversity in the backgrounds of the patient sampled. As well, we are also limited in our understanding of early phase trial decliners, which would be important to understand in order to round out our comprehensive model. So some next steps, findings from this research, I think, point to a multi-pronged approach to support patient autonomy and decision-making about cancer clinical trial participation. Patient engagement and research may offer a way to place patients' needs and interests at the heart of research, ensuring it's not about them, but for them. The Canadian Institutes of Health Research Strategy for Patient-Oriented Research aims to ensure the meaningful engagement of patients in research. Similarly, the National Institute for Health Research in the United Kingdom has developed a patient engagement and clinical development service to facilitate the involvement of patients in clinical trials. Recently, I became aware that Colorectal Cancer Canada is spearheading the development of a Canadian cancer clinical trial stakeholder charter that outlines a shared vision and framework for ensuring cancer patient groups are included as important stakeholders in the clinical trial lifecycle, thereby helping to ensure the centricity of patients in clinical trials and to promote equitable access. A challenge with these important initiatives, however, is that they continue to be voluntary for organizations and industry partners. Another area of potential focus is advanced care planning and goals of care. The emerging study findings highlight the paradoxical nature of achieving informed consent in a circumstance described by many patients as life versus death, and where they perceive no other options but to choose the trial. It is interesting that although the patients we interviewed had advanced cancer, they rarely if ever talked about advanced care planning beyond a trial. There's perhaps room for further exploration of how advanced care planning and goals of care conversations are managed in this context, and how we support patients in valuing all of their options. For example, we know that early palliative care can reduce aggressive intervention at end of life and promote longer and better quality of life than those who do not receive early palliative care. Patients need to be aware of all of their options so that they can make the best decision for their situation. In addition, recognizing that desperation in this context hinders skills of decisional balancing, the ability to offer patients tailored psychosocial interventions with or without caregivers to address desperation and distress in this population may assist with their emotional coping skills and promote their autonomy. Finally, in terms of options, sometimes the only way for patients to access an unfunded drug is through a clinical trial. There is discrepancy across the country of how and whether certain cancer drugs are funded, with sometimes the only option of obtaining a new and expensive cancer therapy through a CT, a clinical trial. Until there is some universality of drug funding across Canada, there will be continued inequities of access and external pressure to enroll in clinical trials to obtain therapies. That's it for me. I'm happy to take questions.
Thank you, Jen, for that presentation. And as many of the audience members probably know, if you wouldn't mind typing your question into the YouTube chat, and then I'll read them out accordingly. There may be a moment for delay. Okay. So while we're waiting, recognizing that there is oftentimes a delay, I'm happy to start off, Jen, and I just thank you for that very insightful presentation. The work that you're doing is so important, and I have a number of questions written down. Many of them have to do with this concept of hope that you brought up. And I think what stood out to me is that participants, it seemed as though the participants you mentioned, that they recognized that there would not be a cure for their cancer, but they were still hopeful for a prolonged life or a better quality of life or this sort of thing. And I'm in no way an expert, and this is why I'm posing the question in terms of all of this, but when it comes to a phase 1 trial, I wonder whether that hopefulness may be seen, at least in certain circumstances, as problematic, given that for a phase 1 trial, oftentimes the goal is really to just gain important information and insight and to possibly benefit future people. And so I'm just wondering what your thoughts are around that conception of hope.
Yeah, it's a really good question. And I think it's very difficult to answer in the new trial landscape. So previously, 10 years ago, I mentioned a literature review investigating patient comprehension to phase 1 trials. And there was an element of therapeutic misestimation and misconception around the purpose of the trial. And because it was based mostly on dose finding and discovering toxicities and so on. The changing trial landscape, though, of today makes things more complicated, some argue, because of the kinds of therapies that are becoming available. So there's really sort of two sides to this debate. I mean, there are some scientists that will say that no, there is sort of there's enough positive beliefs about certain drugs that would warrant a certain degree of hope, I suppose, for them having a kind of an effect that they're looking for. And certainly a lot of these early phase trials are now including some preliminary assessment of effect or efficacy, even though that's not the primary purpose of the trial. So it can be confusing, and it really does seem to depend on the kind of investigation that's taking place, recognizing that this is a lively debate in the ethics literature. There's certainly people that would argue, looking at the history of some of these so-called breakthrough therapy trials and whether or not they have actually been successful longer term once they've been gone through the pipeline, have they actually warranted the hope and belief that was placed on them? And some people will say no. But it is quite a lively debate because others will contest that. So you can imagine that it's hard for the experts to agree. It certainly would be hard for patients to understand what they would be getting into. But it's a very good question.
No, thank you. That's a really helpful answer. And so a couple of questions have come in. And I should have mentioned that if you do want your question to be anonymous, as mentioned in the YouTube chat, just feel free to email Lori. But these two questions came in. The first one is from Melissa McCradden, who says, thank you for such a great talk. Super interested about the idea of naturalness influencing risk assessments. I'm also wondering if you came across anything about individualization of treatment as a factor that influenced participants' decisions, perhaps in the context of precision medicine.
Yeah, so actually the naturalness aspect of it is really intriguing to me as well. And I've given a talk similar to this when we weren't as far along in our analysis, but I gave it at Princess Margaret to some of the teams there, the clinical teams, and kind of probed them about this sense of naturalness around immunotherapies and how patients are understanding it, and then sort of weighing the risks and benefits as a result. And there does seem some clinical validation that, yes, this seems to be an influential factor. So it's interesting. I think it is, people do seem to be, that seems to be something that moves some patients to consider immunotherapies over other kinds of therapies and to desire it more because of the sense that it's natural and it's actually using your own body's immune system and it's less toxic. And I need to just probe that more. I think there is something interesting there. The other question was about individualized treatment. Yeah, that came out in our interviews and in our analysis, that the whole enterprise of precision oncology is actually lending itself what you might think of as a structural influence on patient autonomy decision making, around just the understanding that as we become more able to be more targeted, and again, I mentioned some of the tests that patients go through and the screening practices kind of lends itself to patients interpreting this as moving along as being sort of a good candidate and something that they might individually benefit from. I think all of these factors are sort of swirling around and creating this context where people will be more likely to be hopeful for a particular drug therapy, experimental drug therapy, working for them. So yeah, I think both of those influences are really intriguing and emerging now in this sort of last 10 years or however long precision oncology is sort of being advanced.
Great. So the next question, or it is a comment, but perhaps you can comment on it, Jen, is from Greg Jeffries, who says, very interesting and informative presentation, Dr. Bell. 2 reflections. Number 1, the significance of communication, particularly word selection, when trusted healthcare providers discuss phase 1 CT options. And the second comment is around the huge variation rationales for phase 1 clinical trial decision making means that there's a lot to unpack at the juncture of enrollment within the relational autonomy model. Your research has revealed valuable insights here. So maybe you can just comment on those components.
Yeah, thanks for that, Greg. I think the communication, it's tricky because we did interview clinical trial personnel as well in both of these studies, the later phase study and also the early phase study. And clinical trial personnel believe that they're presenting information in a non-biased way, and perhaps they are. There is the sense that patients are interpreting things the way that they want to interpret as well. So it's a very complex communication back and forth. So we're not just looking at what the provider says, we're looking at how they say it, we're looking at what the patient sort of hopes to glean. Patients will sometimes read into what their providers are saying in order to kind of, like, sometimes patients want more, they want some direction. And sometimes providers will push back and say, we can't tell you what I would do, or I can't recommend what I would do. And sometimes that can feel like sort of an abandonment, but it's really in the sense of we don't want to pressure or coerce patients at all in the decision making. But there is this kind of push-pull. And I think one of the emerging conclusions or next steps maybe that considers how complex the communication is around some of these patient engagement models of research, developing information that that is patient-centered and that has the involvement and input of patients to make sure that they are not only patient-friendly, but they're able to communicate the information that they need to in a way that will be well received by patients. So that's a huge enterprise and well worth the effort, because it's such a fraught relationship and experience. Emotions are high. The other one was about the enrollment. I forgot the other comment.
Yeah, just around that there's a lot to unpack at the juncture of enrollment within the relational autonomy model.
Yeah, and it's not just looking at enrollment, and that is definitely a large piece of this, and it's sort of where we initially focused with the study was around recruitment, and that is certainly a big issue. Interestingly, there is low accrual to clinical trials, and that is a problem. But most people who are presented with the option of a clinical trial will accept it. So really the problem of enrollment is not at the patient level, I would say, it's at the system level around where are we able to offer trials and how are we able to get the information into oncologists or physicians or providers that are at the front lines and are able to communicate the opportunities to patients in some way. And again, that's kind of where some of these strategies are coming into play with just recently learned with patient advocacy groups, for example, where they might be able to help with that sort of intermediary person instead of relying on the clinicians, that there's also these sort of patient groups that can take on some responsibility as well for communicating information.
Thank you. And so the next question that came in is anonymous. And this person says, thank you for your talk. My question is around the fact that many oncologists I've spoken to see clinical trials as treatment options, not experimental options. This can impact the trust that people place in their oncologists, though, as patients won't know or understand that their clinician is biased. We talk about how to educate patients in decision making, but we should also be looking at clinicians and encouraging them to learn about how they influence patients and what it means for research. Can you comment on this?
Yeah, I think there are biases. In fact, the gatekeeping paper that I was part of the presentation that I alluded to was all about physician biases in presenting trials to patients when they're recruiting. And it elaborates on some of those biases that they hold. And I do think that it needs work as well. I agree with the comment and the question that some tools and training, maybe just first becoming aware of those biases. I mean, it could even just be from, it doesn't have to be confusing or believing that a trial is treatment. It could be thinking of a physician, oh, this trial actually looks promising. I actually believe in the mechanism of this drug. I think it's a purposeful trial. I think it's a well-designed trial. And so the bias, if you could call it that, would be around not necessarily a confusion or a blurring between trial and treatment, but actually a preferential stance towards one trial versus another. And when there may or may not be the evidence to support that opinion. So there's lots to explore in this realm too. There's no shortage of questions in this field, it seems.
Thank you. And I think one other question may have come in, but I'm just waiting for it to see. So in the meantime, I wonder if you could, and I guess this somewhat to a certain extent, around just the diversity or the lack of diversity in terms of the participants. And I'm just wondering if you have any thoughts around why that may be the case. And I appreciate that you flagged it and recognized the importance of it. And just wondering why that may be have happened.
Yeah, no, that's a great question. I mean, in terms of our study, I think it's just because it's the kind of population that comes to our institution where we were recruiting. It's sort of a self-selected, in a sense, population that has resources to come to the center. It's in an urban center, so it sort of the population it serves is sort of a certain kind. it's been recognized for many years now that there's a lack of diversity in clinical trials, which really poses a problem for generalizing the knowledge that they hope to produce. And there's lots of initiatives in the States. There's one, for example, around trying to include diverse populations in clinical trials, and there's lots of efforts underway. For example, making clinical trials available, doing some of the trials in community rather than at a comprehensive academic center. So going to where the people are seems to be something that needs to happen. Getting the information out to people with people who they trust to provide that information, for example. So yeah, it's a big problem, and there's several initiatives going on. Specifically, the NIH has supported several initiatives to get the diversity in the clinical trials.
Thank you. And I think we have time for one or two more questions. So one came in from Maria McDonald, who says, thank you for a valuable study sharing the thoughts of patients. Did you also see confusion between the role of the treating doctor versus the role of the researcher?
Maria, do you mean the role of the treating doctor and the role of the principal investigator of the trial, rather than like of the research? Because we had several physicians on our study that were part of our research team. I'm assuming that you mean like the dual role between physician and researcher when they're occupying the same role. They're on their own study. That has come up. That came up actually more in the later phase study. So the earlier study that I mentioned, the ACT model was built upon. That came up more often. There is an ongoing debate about this and how to rectify it, because there's the argument that, well, the physicians who are also the principal investigators are the ones that actually know enough about the trial in order to explain all the risks and benefits to the patient. They're actually best positioned to have the conversation with the patient, and they usually might have that conversation, but then they hive off the actual signing the consent form to the trial's nurse, and that's considered a division of responsibility that is ethically legitimate sometimes. But of course, this study also did point out that patients are influenced by the recommendations of their oncologists, so-called recommendations, when they might perceive it that way, or it might be more explicit. So there I think is reason to be concerned about that dual role, and I don't think it's completely solved by hiving off certain components of the consent process. I think you have to see a consent process as holistic, and each part informing the next. And even what emphasis patients put on, it's probably going to be a lot on their physician's opinion when they highly value that person and they're looking for some kind of guidance from that person already. So yeah, I think that area is fraught ethically and deserves further exploration and considered solutions.
Thank you. And I think the final comment on my list, at least here, is anonymous. And this person writes, a relational autonomy lens focuses in on the structural enablers or constraints on autonomy. This lens may reveal important strategies for improving informed consent and enabling patients to better participate in decision making. But this lens may also work to undermine the autonomy of patients by revealing structural deficits that create obstacles for truly autonomous decision making. Can you comment on this tension?
Yeah, I mean, I think I know what the anonymous comment is about. I mean, when we're concerned about someone having or lacking the skills for autonomy, sometimes the opportunity or the consequence of that is, if you're unable to support that person, to actually say that this person is not exhibiting autonomy and to take away any sort of so-called right to decision making because of it. I think that in this context, it's not. There are many more degrees of autonomy sort of exhibited in this context. I think that there are a lot of ways that we can go about supporting all these patients' autonomy without needing to be paternalistic and overstepping their so-called right to autonomy or ability to make decisions for themselves. So all of the suggestions at the end of my slide deck, and I'd be happy to hear if others have solutions as well, but it clearly requires, because of relational autonomy and recognizing all the influences from various angles, we're not just looking at informed consent here, we're looking at clinical trial decision-making as a holistic enterprise that is influenced by the cancer care experience, how cancer itself is understood within our society, even as a dismal diagnosis, as a C word, as immediately distressing if you receive a cancer diagnosis. So there's a lot of background conditions that a relational autonomy lens would illuminate. And therefore, there's a lot, I think, of avenues for exploration for solutions as well that don't need to go so far as removing somebody's ability to make decisions for themselves, but rather we can focus on, again, what kind of strategies we can employ, like patient engagement and research and some of these other ones that I alluded to support people's capacities for autonomy, recognizing that they are in a position of either needing support in developing or exercising their autonomy at this point. But thank you for that question.
Thanks, Jen. And there is one more question left, so perhaps I'll read it out if you're okay with that. And we have a few minutes left. Is that okay with you?
It's fine with me.
Okay, so this comes from Jed Gross, who says, Jen, thanks for sharing your thought-provoking findings. In science and engineering fields, a distinction is sometimes made between precision and accuracy. A measurement, for example, may be very precisely demarcated, but not very accurate. To the extent that patients seemed enthusiastic about personally tailored treatments, sometimes dubbed precision medicine, might it be helpful to discuss this distinction as part of the consent process?
Thanks for that, Jed. I had not considered that distinction before and the application to this context. So that's very thought-provoking, and perhaps it would be worthwhile. I mean, I think as part of the enterprise of, and there's been a lot of concerted effort recently too in revamping consent forms to make them more patient-friendly and so on. Perhaps in this specific field, there is appetite for exploring this distinction and being able to put it in layperson's terms, so that a greater understanding and therefore a more informed decision can be made. It's interesting, Chad. Thanks for that suggestion.
Thank you for that, Jen, and thanks to everyone for your questions and participation. So with that, it is time to draw today's seminar to a close. I do have a couple of announcements to make before we thank our speaker. Our next seminar will be on Wednesday, March 3rd, where Daniel Buckman and Sarah Levitt will be discussing Towards the Palliative Psychiatry, Ethical Reflections on Futility. To sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca. And CSB students who are enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. So Jen, on behalf of all of us, thank you very much for this wonderful presentation. We appreciate it.
Thank you all for attending.